that the vitreous is still present in the anterior chamber. If it sticks to the sponge, and if it causes a slight tugging on the pupil. Remember, it's better to remove more vitreous than less. If there is inadequate capsular support for a posterior chamber lens, you will need to insert an anterior chamber lens. If available, inject Myocol into the anterior chamber, as this constricts the pupil. Another helpful aid for inserting an anterior chamber lens is a lens glide, which slides across the anterior chamber and helps direct the anterior chamber lens into the correct position. The lower haptic is placed at the 6 o'clock position, and the upper haptic at 12 o'clock is tucked under the upper wound. Finally, a small peripheral aurilectomy is performed, which lessens the risk of pupil block from the vitreous. Sutureless extracapsular cataract extraction is faster and more efficient than sutured. Obviously, there are fewer suture-related problems, such as infection, irritation, and astigmatism. However, sutureless cataract surgery is only for surgeons who are proficient in sutured extracapsular surgery because it is harder to perform. The instruments required for both of these operations are fairly similar. The eye is rotated down with a squint hook and the superior rectus grasped with forceps, and a 4-0 silk suture placed through the superior rectus tendon. This suture helps to immobilize the eye for adequate fixation and tunnel construction, and it will help later when expressing the nucleus through the scleral tunnel. This is by its action in turning the eye down and helping to open up the tunnel. A conjunctival incision is performed at the limbus and light cautery is used to gently cauterize the episcleral vessels. Firm scleral fixation with tooth forceps is needed throughout the construction of the scleral tunnel. A frown-shaped, partial thickness scleral incision is made. The nearest point or apex of this frown-shaped incision should be at least 2 mm back from the limbus. It's useful to make a side port or paracentesis incision into the anterior chamber in about the 8 o'clock position. Viscoelastic can then be injected into the anterior chamber through this incision to ensure a firm eye during scleral tunnel construction. A crescent blade is used to construct this partial thickness scleral tunnel using sideways sweeping movements of the blade whilst rotating the blade between your thumb and 2 forefingers. To ensure the correct depth of the tunnel, just enough of the metal of the blade should be seen. If too much of the metal is seen, then the tunnel is not deep enough and a buttonhole could be made. If none of it is seen, then the tunnel is too deep and possibly a premature entry into the anterior chamber will occur. This tunnel here is a long one for a large nucleus. it will leave some amount of astigmatism, which can be neutralized quite easily by placing one suture in the middle of the incision. However, a broader tunnel such as this one is sometimes easier for inexperienced surgeons, and it is essential for large nuclei. Practice makes perfect, and here we see the opportunity to practice making, first of all, a frown incision and then a tunnel using the crescent knife on an apple. Note how the crescent knife is moved from side to side and gradually advances into the tunnel, in this case, of course, on the apple. The tunnel is now completed with a keratome blade. This slides into the centre of the tunnel, keeping the tip pointing upwards all the time so it doesn't make a premature entry through the back of the tunnel. Once it has reached the end of the tunnel, then point the tip backwards and push it to enter the anterior chamber. Keep the tip in the anterior chamber at all times and use sideways forward cutting movements of the keratome to enlarge the inner opening of the tunnel so that the tip of the keratome just disappears behind the edge of the cornea at each end. There are three main principles for extracting the nucleus. First, the anterior capsulotomy. Secondly, hydrodissection and mobilization of the nucleus to bring it wholly or partly into the anterior chamber. And thirdly, the removal of the nucleus through the tunnel. We will show you here two methods. The first clip shows a linear capsulotomy, partial mobilization of the nucleus into the anterior chamber, and its removal with a fishhook. First, a bent 30-gauge needle is used as a cystotome to create a linear capsulotomy. Balanced salt solution is injected with a cannula underneath the anterior capsule to hydrodissect the nucleus away from the lens capsule and soft lens matter. Then use viscoelastic to mobilize the upper equator of the nucleus into the anterior chamber, as shown in this diagram. It's important to inject enough viscoelastic to push the posterior capsule well back. A specifically bent 30-gauge needle acts as a fishhook to remove the nucleus. It's important to insert the fishhook flat, not pointing backwards, towards the 6 o'clock position. Then rotate it so that the tip engages the nucleus, and then, while the other hand is pulling on the superior rectus suture to help open the scleral tunnel, the fishhook is extracted with the nucleus while pushing gently back on the posterior lip of the tunnel with the shaft of the fishhook. This clip shows how a fishhook is made by 3 bends of the needle. The first creating the hook by bending up to 180 degrees backwards. The second bend of the needle is to the right, and the third bends it slightly upwards. Again, here we see a thorough hydrodissection of the nucleus with balanced salt solution and a Rycroft cannula. The nucleus is then mobilized with viscoelastic. Inject enough viscoelastic to push the posterior capsule back. A fishhook is then inserted flat towards the 6 o'clock position. The nucleus is engaged and extracted while opening the wound with the superior rectus suture and gentle backward pressure with the shaft of the fishhook. Hydroexpression is useful for the epinucleus or for larger fragments of soft lens matter. This second clip demonstrates a can opener capsulotomy followed by full mobilization of the nucleus into the anterior chamber and the use of the irrigating vectis to remove the nucleus. The can opener capsulotomy is done by making small puncture marks in the anterior capsule around the rim of the pupil. At this point, you may try inserting the tip of the cystotome into the nucleus to mobilize it. Alternatively, a hydrodissection cannula can be used to mobilize the nucleus by injecting balanced salt solution at the side of the nucleus and using the tip of the cannula to rotate the nucleus and mobilize it into the anterior chamber. Then inject viscoelastic in front of the nucleus to protect the corneal endothelium and behind the nucleus to hold back the posterior capsule. An irrigating vectis is mounted onto a 5 cc syringe and inserted between the nucleus and the posterior capsule, injecting fluid all the time. Once the vectis has engaged the nucleus, the eye needs to be rotated downwards. The shaft of the vectis must press backwards on the tunnel to hold it open. The vectis is slowly withdrawn from the tunnel, maintaining gentle pressure on the barrel of the syringe all the time, which will give some hydrostatic pressure to help push the nucleus out of the eye. The epinucleus will usually strip off from the nucleus and remain in the eye, and this can be easily removed using a cannula mounted on a syringe or a Simcoe cannula, whilst maintaining backward pressure on the tunnel to allow the epinucleus to come out. The remaining soft lens matter is then carefully and gently removed using here a two-way irrigating aspirating Simcoe cannula. Gentle suction can be applied to the syringe using the thumb and fingertips whilst maintaining constant irrigation. Using the side port maintains a very deep anterior chamber and makes this irrigation and aspiration much easier. The capsule bag is then inflated with viscoelastic and a single-piece PMMA intraocular lens is placed gently into the posterior chamber and dialed clockwise into place. The anterior capsulotomy is completed with a pair of micro scissors and then capsule forceps or a Simcoe cannula used to remove the piece of anterior capsule. The Simcoe cannula is then used for a thorough irrigation and aspiration of all the remaining viscoelastic. A subconjunctival injection of steroid is given, usually with antibiotic, and here cautery is used to bring the conjunctiva together, but if the subconjunctival injection is given into the upper conjunctiva, that will help to bring it down over the wound. For paediatric cataract surgery, a posterior capsulotomy and anterior vitrectomy needs to be performed. Otherwise, posterior capsular opacification will develop very quickly and reduce vision dramatically, even within a few weeks. More postoperative inflammation or uveitis is seen after paediatric cataract surgery than adult. Paediatric cataract can be an emergency, as amblyopia from not being able to see through the cataract can develop in weeks and can cause permanent visual impairment. Paediatric cataract surgery should only be performed by a paediatric ophthalmic specialist unless there is absolutely no possibility of one being available. Here we will show a clip of an expert paediatric cataract surgeon performing. Here a diamond blade is used to create a scleral tunnel and trypan or vision blue is used to stain the anterior capsule. An anterior capsule continuous curvilinear capsulorhexis is performed using a cystotome at first and then fine capsule forceps. This can be very difficult as the pediatric lens capsule is much more elastic than in adults and tends to tear out to the periphery. For this reason, it's best to perform pediatric capsulorhexis either with expensive, high-quality viscoelastic such as Helon, or even better, Helon GV, or alternatively with an anterior chamber maintainer connected to an IV drip bottle, which will maintain downward pressure on the lens, and this helps to reduce the risk of the capsulorhexis tearing to the periphery. Once the continuous curvilinear capsulorhexis is complete, then balanced salt solution is used to hydrodissect and hydrodelineate the nucleus. A Simcoe cannula is used here to aspirate the nucleus because the nucleus of a child is very soft and can be aspirated in this way. And of course the cortical and soft lens matter can also be aspirated using a Simcoe cannula. Alternatively, bimanual irrigation and aspiration can be used to aspirate the remaining soft lens fragments. The irrigating cannula is held in one hand and the aspirating cannula in the other. Now again, the cystotome is used to create a posterior continuous curvilinear capsulorhexis under viscoelastic. This is usually much easier than the anterior capsulorhexis